thank to the organizing committee to inviting me to join this session. So first of all, I think I have to focus on two objectives for this session. The first one, I would like to share the new definitions of metabolic associated fatty liver disease, which come instead of the term of non-alcoholic fatty liver disease. And the second one, I will review the current management of Nash, especially in patients with HIV. So first of all, you can see the epidemiology data on the NAFL across the world. It's quite commonly found in your clinical practice. Around 1/4 of your patients should have some evidence of a fatty liver. Especially in Asian data, we confirm of around 1/3. And it's usually present in high prevalence or high proportion in those with obesity or diabetes. So in terms of NASH, it means that focusing on the fatty liver with inflammation of the liver, which show in abnormal level of a liver function test. So that is just the screening test, but we have to confirm by liver biopsy to say that the patient have NASH or non-alcoholic steatohepatitis. And around 7 to 10% of them have advanced fibrosis. That's the key that we have to focus on because this group can turn out in long-term consequence with liver complication, including cirrhosis and hepatocellular carcinoma. Regarding to the patients or people living with the HIV, so how common of a fatty liver in this group? As this study from Vienna, as you can see, this is the retrospective study during 2014 to 16. And you can see that the mean age of the patient is quite low, around 37 years old. And most of them receive the ART throughout the duration of follow-up. And the median CD4 count is quite high. So 62% of them have normal weight. That means there is no any evidence of obesity at all at the presentation. From this study, we found that the fatty liver accounted around 16% at baseline. And when follow-up around 6 years, it's increasing up around 18%. So it's quite common to see patients living with HIV show evidence of fatty liver. The second study comes from India. It showed the same results and interestingly from this data, they found more common or more proportion of fatty liver in this group. It take around 60%. And again, 45% of this group show as a lean fatty liver or BMI less than 23. So this is the key that different from fatty liver in general population that I talked already is usually present in those with obesity and diabetes. So I will move on to the new term or new definitions of fatty liver that I mentioned from non-alcoholic fatty liver, move to metabolic associated fatty liver disease. Why it have to be changed? Because the hepatologists communities agree and discuss in terms of more positive diagnosis rather than a non-disease rubric. And again, they still confirm that we need histological biopsy or imaging or blood biomarker for diagnosis of liver fat. And they classify metabolic associated fatty liver disease in 3 subgroups. The first one is obesity or overweight. The second one, the fatty liver that present in diabetes. And the last one, we call lean fatty liver or those with BMI less than 23 in Asia or 25 in white people with evidence of metabolic dysregulation. This definition and sub-classification is quite important to mention in detail. This slide, I want to show you that why the MAFL is quite more acceptable right now because you can see all the group of patients with other chronic liver disease that present with fatty liver, such as the group of HIV patients or even those with viral hepatitis, they can present two diseases in the same person, viral hepatitis plus fatty liver. And we have several data showing that the fatty liver aggravate or can cause more progression of liver disease in this group patient. This slide to show you the three categories that I mentioned already. Though I want to show and emphasize on those with a lean fatty liver that accounted around 6 to 70%. And diabetes is another group that we separate from obesity because the disease progression in diabetes is more faster than other groups. I didn't show the data for HIV in this slide, but my review showing that the HIV patient can present with diabetes. It's around 7 to 25% during the follow-up periods, especially those with on ART for a long time. So this is the evidence that you should keep in mind that is quite high prevalence of risk of fatty liver in patients living with HIV. And one more important thing is that MAFO is the term that's more acceptable and should be used right now because of this data. This data came from United States. The key highlight of this data is to compare between two terms of MAFO and NAFO. It's showing that the MAFO definition can detect all-cause mortalities and liver-related mortality higher than the definition that you use by the old term of NAFO. So I think in clinical practice, MAFO should be emphasized and used in general population, including HIV. And to make it clear that if we use the term of MAFO, it shows the same result that the MAFO cases show high all-cause mortality and is especially higher in those patients with more advanced fibrosis. As you can see from this graph, those with F3 or F4 have a higher rate of all-cause mortality. And this slide also confirms the rapid growing cause of hepatocellular carcinoma in general population, and Nash is account the most proportion of SCC in this era since 2016. Another point, I think this is a growing evidence that extrahepatic complication in those with NAFO or MAFO is increasing. Two common diseases that we're focusing on is one is cardiovascular disease and another one is CKD or chronic kidney disease. It's increasingly, especially in those with F3 and F4. So I think this data mainly come from the general population, but in area of HIV, I think there is very few data to confirm that. I think keep in mind you can explore the data of HIV group with these extrahepatic complications should be explored more. So in summary for the definition, I think the MAFO is promising to use because of they can improve to apply in all area of patients and in health system. It can allow to certify those with three subgroups, as I mentioned, and it increase disease awareness in general population, including with the community of patients living with HIV. So moving on to the second part, I think how common of this disease progress to be cirrhosis or to have some complication. As you can see from this slide, if we counting on the patient present with NASH with some degree of fibrosis, especially those with F3 and F4, we call the rule of 20%. Around 1/5 of patients will progress to be cirrhosis in just 2 years. And if you show the evidence of cirrhosis and then you follow up for the next 2 years, 1/5 of them will show you with a symptom of hepatic decompensation. What is the key predictor to show a hepatic decompensation during follow-up? You can use MELD score, you can see the clinical or portal hypertension, or you can use non-invasive test, which is available in in your clinic, such as non-fatty liver fibrosis score, FIB-4 score, or a PRI score. This is just the simple test that you can use the simple labs, such as CBC, AST, ALT, to calculate. By use your Google calculator, you can find that and you just do it. This slide to show you the current tools to assess severity and predictor of liver fibrosis. As I mentioned, fibrosis, especially those with F3 and 4, are the key part that we have to focusing on the patient with fatty liver. I propose one that commonly used in hepatology community is the FIB-4 score. It's very simple test that you can use just 4 parameters, including age, AST, ALT, and platelet. So it's simple. You can use by calculator. You can ask your nurse or coordinator to help you to calculate it. And it's classified as a low risk, such as less than 1.45, or higher risk for advanced fibrosis that more than 3.25. And it was validated in several studies. And to summary and make it short, there's two tools that commonly used in hepatology communities. The first one is transient elastography. There's some machine to use acoustic vibration to your liver and then receive the wave that back from the liver, and the data are count into the unit of kilopascal. The second one, FIB-4, that I just mentioned. So these two tools, if you have any of them, you can use it with the high AU, ROC, and high sense and specificity for detection of advanced fibrosis. Again, this is just to show you, you can Google and you can find this slide, and you can calculate it. Very simple. Just within a minute, you can get the data from the patients. And again, this is just published a few months ago that this is the survey study from hepatologist communities, and asked the hepatologists which one that you use to assess the liver fibrosis in your communities. And most of them use the FIB-4 and TE or transient elastography. So if you have them, use them please in your services with patients with HIV. Our group with friends from Asia Pacific countries, around 9 centers in tertiary care, we get the case around more than 1,000 cases with the liver biopsy proven. And then we use the combined or two-step approach to identify those patients with advanced fibrosis. The first step is to use a scoring system, even FIB-4 or other scoring system that you use. And then you use the second one in those with high chance of advanced fibrosis from FIB-4, such as in this slide show. So around 2/3 that have shown the data of low FIB-4 or low risk of advanced fibrosis. So you can follow up them yearly, or it's not the case of serious to concern, something like that. Around 1/3 that have the indeterminate or in high risk group, or FIB-4 is quite high. You should use the second tool, such as transient elastography, to determine is again. So if it's confirmed that the patient have high liver stiffness measurement from transient elastography, this is the high risk group to focus and taking care. If it's still indeterminate, this group, you should proceed to do liver biopsy to make the definite diagnosis. So it helps you to reduce the non-necessary case to follow up in short term or period of follow-up. So this is just published ahead of our American Association of Liver Disease, which is will be published soon in the next few months. They summarize that they recommend to screen for advanced liver fibrosis in high-risk group, which is including with type 2 diabetes, morbid obesity, or those obesity with complication or with comorbidity, fatty liver with alcoholic use, and first-degree relative of patients with fatty liver present with cirrhosis. So as you can see, as I start them, there is a prevalence of this advanced fibrosis accounted for 1/5 or 17 to 33%. This slide I would like to share with you about is worthwhile to screen for advanced liver fibrosis in patients living with HIV. In fact, there is no data to confirm that, but I would like to share you with this meta-analysis data. This is the data from 2017, and as you can see, in patients living with HIV, the prevalence of fatty liver is around one-third, 35%, and advanced or significant fibrosis is accounted for 1/5. So it's quite high. And predictor for significant fibrosis is including for high BMI, high blood sugar, and high ST level. In comparison to the recent meta-analysis in this month from Lancet, is study in obesity and overweight. This is a meta-analysis that includes patients more than 100,000 cases. As you can see, the number of prevalence of fatty liver and significant fibrosis is quite similar to those with patients with HIV. So I leave to you to decide should to screen or not, but in my opinion, it's worthwhile to do that. So this is the guideline recently that I just mentioned. The guideline of AASLD conclude that you can use the two steps, as I mentioned. The first step, you can use the FIB-4, and then if you have some abnormal or high FIB-4, which is mean high chance of advanced fibrosis, they use cutoff of FIB-4 more than 2.67, then you refer them to the hepatologist or GI, and then the GI man will screen again with the second step, including transient elastography or other modality, and to identify those with advanced fibrosis for further management. This is the care pathway for fatty liver recently. So the next one is to summarize the current management of NASH. Again, most of the data that I will talk to you is just come from the general population that most of the study exclude HIV. But as I mentioned, I think if HIV with fatty liver is the same, HIV is the same as a clinical presentation with fatty liver in general population or not. As I show you the data, I think it's the same. It's no any difference, just only lean fatty liver that more proportional found in NASH with HIV. So the first one is focusing on the diet recommendation. Again, you have to advise the patient to reduce the overall caloric intake around 500 kilocalories per day in general. The second one is some certain food, especially oily food or high carbohydrate proportion, you have to advise to reduce. Especially, I think in Asian countries, Thailand is one of the country that love to eat or drink some fruit juice or other diet that's very sweet. So sugar is the enemy or the risk factor for fatty liver. So please focus on that. And aim to lose some weight. In general population, we recommend around 7 to 10% for weight reduction and to achieve improvement of liver fibrosis and steatosis. But in those with lean fatty liver that I mentioned, especially in HIV patients, the aim of weight reduction is reduced to only 3 to 5% is enough to improve liver function and improve liver histology. This is a summary of the nutritional treatment as I mentioned. So focus on the aim of weight reduction, focus on low fat, low carb diet. Some proposal of Mediterranean or other kinds of food to use is depend, but I think mainly you just reduce fat and carb is enough. And Mediterranean diet, what is it? Is the components of carbohydrate is accounted for around 1/3 of total calorie, fat around 1/3, and focus on high MUFA or PUFA, and protein account around 1/5 of proportion. And recently, I think you can facing with the consultation of patient consult with keto diet or some diet that composed of oily food, which is, can help or not. By the evidence base, it can reduce or improve body weight around 5 to 6%. But the problem is the compliance. It means you cannot tolerate this kind of food for long term. So that's the thing. And another one, especially those with diabetes, which if you use the keto diet, is have a risk to have some ketoacidosis in the body of the patient. So be aware of this side effect. Another things that the patient usually mention and consult you is about IF or intermittent fasting. Is it true to improve your body weight in case of patient with fatty liver? Yes, it is. There's some evidence of around 8 hours that you eat and then you fast around 16 hours in a small size number of cases, and it can improve and can reduce body weight around 5%. So you can use it. It depends on your lifestyle. But I think the overall issue is to reduce total calorie per day. How about the physical activity to help and to reduce the risk of liver complication in this group of patients? Again, they recommend to work out or to do some exercise for at least 3 hours per week. And it could prevent around 25% of liver-related death. As you can see from this slide, if you have a higher BMI, I think you have to do more work to achieve the goal. So again, if you can reduce food intake, I think it's more convenient and easier way in comparison with exercise. I think if you can run around your area of around 2 or 3 kilos per day, you will know that it's very exhausting, and I think you can come back and reduce the intake. It's much easier. So this slide just the summary from ASLD in 2022 for the medication that can be used in general population. Again, there is no any strong data support in HIV, but if you want to use it, I think the first two medication is quite safe. There are some data in HIV, especially those with diabetes, including pioglitazone. You can use it. It can reduce some inflammation. Vitamin E high dose, 800 units per day is also useful. But all the data from general population, the duration of taking this medication to see the improvement, we use the timeline around 6 months. Normally, you should see the improvement of liver test in 6 months. If 6 months is still fail, I think you have to reconsider or stop or reevaluate the patients. For the last 3 medication, this is the new one, and they propose to use in those with obesity plus diabetes, because it's the booming medication for endocrinology society. The 2 main one is liraglutide or semaglutide or GLP-1 receptor agonist. And the second group is SGLT2 inhibitor. This medication show the potencies of diabetic control, reduce body weight around 6 to 10%, as well as the key highlight of their benefits is to protect cardiovascular disease. But the problem of 2 or 3 kind medication that I just mentioned is the high cost. Even in Thailand, it's accounted around 10,000 baht or more per month. So it's quite expensive. So again, if we can find the medication, copy one that cheaper, is like in community of HIV with hepatitis B or C. If we can get the good drug with a reasonable price, I think these 2 or 3 kind medication is quite interesting. So as I mentioned, the key highlight of GLP-1 analog and SGLT2 is to offer cardiometabolic benefit, especially in those with type 2 diabetes and fatty liver. So this is the new one that we moving on in general population to use. Another area that I got consultation from the communities very often is that we use statin in those with fatty liver. Because of, I think in the old era, most of our patients, including doctor, are afraid of side effects, especially hepatitis from statin. But nowadays, I think, especially in database from liver talks that see the drug-induced liver injury in communities, they found that statin is quite safe and it's not different from other medication commonly used in practice. So I emphasize that if you have indication to use statin, especially in those with high lipid levels, especially LDL, with other risk or comorbidity for cardiovascular risk, you can use it. And this is our study to do meta-analysis to confirm that statin in case with fatty liver in several studies, including for about 150 cases, you can see that it's not the risk, but it's also decrease the steatosis and inflammation in those patients with fatty liver too. So keep in mind, it's safe, consider the indication, and you can use it safely with monitoring as usual. What is the new target of upcoming therapy for fatty liver? There are the big area of current study focusing the new medication in fatty liver because viral hepatitis now is sunset already because there are medication very cheap to get rid of them. So fatty liver is the new topic to focusing. So you can see that several groups of medication that coming up, especially the FXR agonist, PPAR agonist. This is the two focusing medication, and you can see the detail in the reference that I show you. Last but not least, I think the care for fatty liver right now is not the area just only for hepatologists. I think the primary physicians, the GI, the nutritional specialists, or other area health workers have to help together to manage the patient to achieve goal of weight reduction, lifestyle change or modification to achieve the improvement of liver steatosis and fibrosis. So in summary, ladies and gentlemen, I would like to show you that just only two key points. The first one, I think to screen the Nash in patients living with HIV is quite necessary. With the evidence that I show you, I think it's quite interesting to do it. By the first one, I think you have to exclude viral hepatitis because HIV patients have the risk to have some viral hepatitis that we just mentioned. And then you use the simple test or non-invasive test, including FIB-4 or combined with transient elastography to identify those with F3 or 4. And if you found that those with high-risk group, you can refer to GI or hepatologist for confirmed diagnosis and start the treatment, and definitely to screening for SCC yearly or every 6 months. It depends on the facility. The second one, as I mentioned, the management right now still based on the lifestyle modification to achieve the target of 7 to 10% in general obese group or 3 to 5% in lean fatty liver. Current pharmacotherapy is focusing on vitamin E. Pioglitazone is the one that's quite safe right now. We have a lot of information to use it. But again, in difficult case, that means those with diabetes and obesity, we're moving on to use GLP-1 analog and SGLT2 inhibitor. The new medication is coming, and I think in difficult case that morbid obesity, I didn't show you the detail, but surgery, especially morbid obesity surgery, it can help and achieve the goal to reduce the body weight. And finally, I think the fatty liver is the area of multidisciplinary to help together to achieve the goal of care. Thank you, and I welcome for the questions.
Thank you so much, Dr. Sombat. We will have time for one quick question from the audience. If you have any question, please come up to the microphone. Maybe I can ask a quick question, Dr. Sombat.
Thank you.
So, recent findings from the different cohorts mentioned the ART association with the nephrology people living with HIV, for example, TAF or integrase inhibitor. Do you think there's a concern regarding ART-induced steatosis?
So TAF, there's some side effect of hypercholesterolemia, as you know, right? It's around 20 to 30%, but the level is not quite high. So if you think about that, it can have some consequence to add on the risk of increasing fatty liver. But there are some study in those chronic hepatitis B using TAF and plus with the lipid lowering agents such as atorvastatin. It can control level of cholesterol to near normal or to normal level. So I don't think it's the key role to offer TAF to add on the list of fatty liver. So you can use it. Don't worry about that. And if high cholesterol, just start anti-lipid lowering agent.
Thank you. Thank you, Dr. Sombat.
Thank you.